My talk is on therapeutic keratoplasty, but this is not a debate because I don't think there is any clear-cut distinction between early intervention and late intervention. It all depends on the individual case. So basically, these are the factors that we use in infectious keratitis. Obviously, you have the infiltration, but apart from that, what you also take a look at is the inflammatory component and what is happening to the other ocular structures within the eye. So most decisions that you see basically taken based on the size and the depth of the infiltrate, also whether you have recalcitrant to therapy. And I think in such situations, all of us agree that you're going to do a surgery immediately when you have a large recalcitrant infiltrate, when it extends to the limbus, when it does not respond to therapy, you have a decimeter seal or you have an imminent perforation. What happens, however, when you have a large infiltrate? You require a larger graft. So fundamentally, what you have is more inflammation as the duration is usually longer. You have more chances of limbal involvement. You can have limbal stem cell deficiency. And post-operatively, this will manifest as a persistent ED and intense vascularization of the graft. The other important thing is that you have a lot of distortion of the angle. The larger the infiltrate and the larger the graft, the more distortion of the angle that you see. Secondly, when you have a large graft, the risk of rejection after therapeutic keratoplasty is much higher. You also have more peripheral anterior synechiae, and there's also intense vascularization of the graft. Obviously, the risk of recurrence is also higher when you have a large graft. So these are some of the points that I use when I'm making a decision about when to interfere. One thing is the endothelial plaque. The endothelial plaque usually spreads much more rapidly than the surface infiltrate, especially when the surface has healed. Very often you will find that the patient has healed, gone home, and then he comes back with an endothelial plaque. And what you see is that there'll be no epithelial defect at all. Part of the reason is because of the penetration of the molecules of the medications that you use. NATA is around 3 to 4 times larger than voriconazole, and once the ED heals, the penetration of NATA is very, very poor. So I've seen cases of fusarium where you have just an endothelial plaque coming back again after you've stopped therapy and send the patient home. So a spreading endothelial plaque is one risk factor for me to use for going in for a early keratoplasty. Look at this particular patient. Look at the infiltrate is quite well defined. Sorry. The infiltrate is quite well defined, but you see how much of the plaque is spreading closer towards the lens. Now, the AC is a guide to timing intervention. Basically, whenever you have an infection, you have a breakdown of the blood aqueous barrier and you have leakage from the iris wells, so your iris becomes boggy. In a lot of cases, you have frank neovascularization. So what happens? You have an increased risk of peripheral anterior synechiae, PAS, as well as anterior and posterior synechiae. You have an IOP spike, you have a complicated cataract as well as glaucoma. So in such situations, even if the infiltrate is healing, I will go ahead and do a therapeutic keratoplasty because of all the other ancillary changes that are taking place within the eye. In these three cases, I will not interfere at all. This is a Pseudomonas aeruginosa, well delineated, responding to therapy. The only concern here is the fact that there is some thinning, which should probably come down with reducing the antibiotics and probably giving some doxycycline and patching. This is a strep new infection, absolutely no AC reaction, but I don't like the way the sclera looks. So keep a close eye on this case and see whether the lid edema and the scleral inflammation is increasing. If that is so, I will go ahead and do the surgery. This particular patient, I'm just going to handle with intrastromal voriconazole for the time being. I'm not going to do it because I'm using the AC as a guide, and I also use the fact that the lesions are central and well defined. So what happens when you have inflammation? One is that you have increasing congestion and lid edema. So intraoperatively, what are you going to get? You have higher chances of an expulsion of the lens, vitreous loss, and probably remote an expulsive hemorrhage. When you have an increasing AC reaction, the aqueous becomes fibrinoid, and you also have a hypopion. So what happens once again? You have PAS, synechiae, trabecular meshwork damage, and secondary glaucoma. You also have progressive lens changes. Sometimes the cataract can become intumescent or become a mature cataract very quickly. Glaucoma, we'll talk about it again later. Just about all the mechanisms come into play, both angle closure as well as open angle mechanisms. You can also have a spillover into the posterior segment, reactionary vitritis, and intumescent cataract, as well as vitreous hydration. So coming to glaucoma, just about everything that we have read in blue shields, all the mechanisms come into play over here. One thing is that trabecular meshwork damage by inflammatory products or occlusion occurs early. And the long-term consequence is that you can have permanent structural damage to the trabecular meshwork. You can have a pupillary block glaucoma. You can have secondary angle closure due to path and an intumescent lens. The episcleral vessel drainage can also be affected. You can have ciliary body effusion. And fundamentally, you have very poor outcome when you combine trab and drainage devices with the therapeutic keratoplasty because of the inflammatory reaction. Take a look at this particular patient. This is a small central infiltrate, but you've done the therapeutic graft here and look at the amount of occlusion. The trabecular meshwork is totally closed off. So you will have to do a trabeculectomy or a drainage procedure down the road, but you cannot do it in the inflamed state. These are all pictures of patients where intervention has been delayed, and take a look at how the angles look like. There's so much of the anterior chamber is closed off, the trabecular meshwork is closed off, there's absolutely nothing left. So how are you going to translate that into visual acuity later for the patient with a penetrating keratoplasty? After all, the goal of everything that we do is not just to control the infection. We do want to make the patient to see something too, right? So the type of infiltrate also matters. For example, a fungal keratitis, like Dr. Radhika mentioned, the inflammatory reaction is much more, and so therefore you would expect more post-op complications. So the timing of intervention is earlier for a fungal keratitis than for a bacterial. Bacterial keratitis, you have least amount of inflammatory response, except maybe for strep pneumo and maybe Bacillus cereus. But what happens is when you open the eye, you will not usually find NVI. You will not find dense adhesions. You won't find a cyclitic membrane, and the lens will usually be clear and less chances of the lens popping out with a bacterial keratitis than with a fungal keratitis. Acanthamoeba, an intimate kind of an approach, but can be severe when you have scleral inflammation. So this is a patient with a fusarium infiltrate. Somebody has done a large graft, 10.5 millimeters. You're bleeding from the NVI. The patient is aphakic because of an expelled lens, and he already has secondary glaucoma. So intraoperative with the fungal keratitis, these are all the things that you can see if you delay the surgery. Bleeding, adhesions, a peripheral anterior synecdoche, an altered iris pattern. Here you can see that the entire posterior pigment epithelium of the iris has been pulled into the pupillary area because of the inflammatory response. You have cataracts, and you can also have a cyclitic membrane, as you can see in this particular picture. This is actually just screenshots of all that of a surgery that I've done maybe 15 years ago. Look at the infiltrate and look at how bad the entire eye is. By the time the lens has come out and everything, the eye is already started to collapse. So there's no point in basically doing this surgery. And I'm not going to get anything out of it, or the patient is not going to get anything out of this. So these are some of the cases, early post-operative, we have delayed intervention. Look at how the eye looks. So when you take a look at what you want for the patient in the future, I think for all these cases, we should have interfered earlier, or at least the patient should have come earlier to us. So this is late post-op. You can see that there is no limbal demarcation. Everything is stuck together. And this is a case which probably would have benefited with an earlier surgery. But surgery was delayed, and this is how it is. How are you going to translate this into penetrating keratoplasty down the road? That is the question that you always have to ask yourself when you decide when to interfere. Obviously, some cases we have no choice. But so many cases you can decide what to do, thinking about what your long-term goal is. It's not just eradication of the infection. So if you take a look, what makes for a good graft? One, you need a clear graft. It's well within the limbus. You have a deep and a quiet AC and a normal IOP. This is what you want, right? But take a look at this patient. What you find? You have a large graft. It's fairly clear. But the graft host junctions are already there. You have a pseudopterygium coming in. AC is shallow. You have lots of areas of pass. The pupil is dilated and fixed, is aphakic, and the patient has secondary glaucoma. So the chances of rejection of failure is much higher in this particular patient. And you could consider an esophageal, but once again, you're going to have a lot of problems dealing with the glaucoma. So fundamentally, the approach to the TKP is what the pre-op status is sets the course for what you see intraoperatively and also post-operatively. And you need to differentiate based upon the type of infection and what to expect with a bacterial keratitis. Strep and Pseudomonas, strep will have a little bit more of inflammation, Pseudomonas less so, and fungal keratitis in AK, what you see intraoperatively is a lot more. What happens in the anterior chamber is as important as what happens with the infiltrate, and you cannot replace your angle. You can do another graft, but you cannot replace the angle. Both trab and drainage devices fare poorly in the inflamed eye. And when you come to a large graft, you can have distortion of the angle, limbal stem cell deficiency, persistent epithelial defect, rejection, failure, secondary glaucoma, etc. I have a few slides just to show how we approach some of the cases. This is partly spills over into the previous talk, but I also want to make clarify one thing that I'm not an advocate of using steroids all the time for fungal keratitis. It's only for certain select cases that I use steroids, okay? So this is a patient who presented to a hospital with a 1 month history of pain. He was treated with steroids, antibiotics, as well as antifungals. And when he came, he just had a 2.5 millimeter paracentral anterior stromal infiltrate. It also received 3 injections of intrastromal and intracameral voriconazole, and Aspergillus species was grown for the patient. Now, he had done well, but then suddenly he came on 1310, everything had flared. He had an endothelial plaque also, and the IOP was spiking. So we went 1410, we did a therapeutic keratoplasty. We managed to get good, had a good button, and we had good margins also. The button was positive, and the size of the graph was 8.5. The lens was still retained. This is a point that I would like to mention. One of the things that happens when you retain the lens has huge advantages. You can remove the lens very easily during your therapeutic keratoplasty, but you can have a PCR. The second thing is that if you have noticed, um, the adhesions that form between the iris and the anterior capsule can be easily dissected out, but adhesions that form between the iris and the posterior capsule are very difficult to dissect out. When you put in a secondary IOL, even when you have a retained PC, it's much more difficult to center the iris. I'm sure all of you all have had this experience. So what I've started this patient on was since it was an aspergillus and we have come close towards the limbus, I started the patient on Nepaflam for 3 weeks. One of the things to watch out for is a persistent epithelial defect, so you cannot give this drug for long. On 2510, that is probably around 13 days after surgery, I've started oral steroids, and on 3011, I've added Talimus. This is a deference to the fact that this patient has aspergillus culture button positive. Predforte was added around 3 to 4 weeks later. Now, almost a month later, his vision is uncorrected visual acuity 636. The graft is clear, there is no pass. His lens is there, lens is also clear. But this is somebody whom I can transition from a therapeutic keratoplasty into an optical grade penetrating keratoplasty. This is another patient treated with antifungals for 35 days elsewhere for Aspergillus keratitis. He had resolved and again came back again with a recurrence with an endothelial plaque. And we did a therapeutic keratoplasty one day after I saw him. 2710, this is what he looks like. The lens is still retained. This is one of the biggest advantages that I would like to talk about. And the other thing is, yes, you might have a complicated cataract developing in 3 to 4 months, but that's fine. You're not going to be operating on a hot eye. So once again, for this patient, the Nepaflam was given 3 times a day. The Predforte was initiated 511, which was a little earlier than what I wanted, but the patient is doing well. Tacliment was started around 1311 and oral steroids also. So the patient has 5/60 vision, and right now he is where I want him to be, except for the fact that he has a lot of posterior synechiae. But since the lens is retained, I'm not very much bothered about this, and I also have a deep anterior chamber. This is a patient, one-eyed patient, who came one day in the evening to the OPD with a massive graft infiltrate. And clinically, it looked like pseudomonas. Since it was late in the evening, I thought she needed a therapeutic keratoplasty almost immediately. But then since it was the evening, I admitted her, started her on 3 fortified antibiotics, piperacillin, amikacin, as well as cefatoxim. The next day, I thought I'm going to put her, I'd already scheduled her for the therapeutic graft the next day, but I saw her before it, and then the infiltrate was still the same. So I backed off from doing a therapeutic keratoplasty on a hot eye. Over the next few days, I monitored her. The infiltrate slowly started consolidating and confining, but at this particular area, the graft started to give way. Fortunately, still didn't perforate. So I kept a hold on it, started an autologous serum as she was already on doxycycline, started an autologous serum on the third day. Finally, when I went in for surgery 9 days later, the infection was totally under control. And intraoperatively, I based the sizing based upon how this felt to touch. You know that in pseudomonas, you have a lot of melt. My idea was that she was a one-night patient, and I didn't want to do a limbus to limbus graft for her. So when I went into the OR, I went all around these edges, checked how the tissue felt, and then determined the size of the graft. So I was able to do a 9.5 graft. So 10 days after keratoplasty, you can see it's a pretty good, looks pretty good. Her uncorrected visual acuity is 5/60. So this is a patient, a fusarium, approximately 1 month after keratoplasty on steroids for 2 weeks. And then she comes in with this little, she was doing well in the beginning, and then there she comes with a small little infiltrate over here 1 month after keratoplasty. Mind you, this particular infiltrate, if you take a look, once you wash off the anterior chamber exudates, you will find that the lesion is much smaller than what it actually looks like. The sizing for this particular graph was based on that, and I'm just wondering maybe that was wrong. Perhaps we should have gone for a larger graph for this particular patient. But then when we saw the patient 1 month later, we had a tiny little infiltrate, but it took, I had to stop the steroids, stop everything. We had to give her 2 injections of intrastromal voriconazole, added povidone, added before this resolved. During that time, the graft has failed. So since that occurred a month later, and for such a small infiltrate took such a long time, I did not go back to giving any steroids for this patient, allowed the graft to fail and planned for intervention 6 months later. This is a patient with acanthamoeba, 117 diagnosed with acanthamoeba keratitis, culture negative at 3 months, okay, and steroids were added at that particular point of time. 417, he comes back with a recurrence, the steroids were stopped. 617 is a nice little scar, somebody added steroids again. 717, this is what he looks like. Comes back again later with another recurrence a month after, and then a therapeutic keratoplasty was done. Steroids were again stopped. The patient had an epithelial defect, and so the steroids were stopped. It was non-healing, so a tassorrhaphy was done, and ME besides, again it healed. 518, the infiltrate had healed completely. Again, I don't have a picture of that. 718, again, there's a recurrent ulceration, steroids were added, cysts were positive, and 319, this is the end result. So the point I'm trying to make is that this is individualized. To say that you can do, there is a blanket method of doing, adding steroids or immunosuppressants for patients is not really there. Every patient is individualized. That is the point I'm trying to make. And this is obvious, this is not a therapeutic keratoplasty. I'm sorry, I accidentally put this in. But this was a steroid-treated patient who was AK positive and a confocals at both hyphae and cysts. And patient was treated with chlorhexidine, PHMB, voriconazole, as well as NATA. And after this intensive treatment, the steroids were started for 3 weeks after this, and all the drops were continued hourly. At the end, this is how he looks like. It has healed very well. So one of the points that I would like to make is that generally when people start steroids, they think, okay, we have things under control. They were going to taper the antifungals as well as the anti-amoebic agents. My thing is that don't taper. Keep it going for some time and watch very carefully. And I usually start predforte twice, then I increase to 4 times, 3 weeks, a week later. But I see the patient almost every 3 days for the first 1 month or 45 days before I say, okay, I have things under control. That being said, I've still had infections, the patients coming back with recurrent fungal keratitis 3 months after starting, 3 to 4 months after therapeutic keratoplasty, after initiating steroids much, much later, not even in the beginning. So that is also there. So thank you very much.